Hello, this is Amber. We are going to discuss Chapter 19 on behavior disorders. We're going to cover depression, anxiety, eating disorders, attention deficit disorders, and pervasive developmental disorders. Depression is characterized by the feelings of sadness, low spirits, gloom, disappointment, frustration, dejection. These emotions are usually in response to a loss of life, life frustrations, or disappointments. This was a survey done by the CDC back in 2008, categorizing the states where the adults meet the criteria for depression. Clinical depression is referred to as the common cold of psychiatry. Its highest lifetime disorders coming in at 17% and diagnosed at a mean age of 40 years old. It occurs concurrently with the rise of morbidity, mortality, and disabilities. These socioeconomic factors that contribute are loss of income, loss of job, single parents, economic deprivation. There's symptoms that are associated with it. Physical disorders include multiple sclerosis, encephalitis, systemic lupus. Organic disorders are cerebral ischemia, tuberculosis, electrolyte imbalances, vitamin deficiencies. And then we also have our pharmacological agents. Those are things such as beta blockers, estrogen, antiarrhythmics. Can also cause depression type symptoms. Here we have theories of depressions. You have your psychodynamic theory, which is depression is associated with the perceived difference between the ideal self and the actual self. Behaviors theory is a learned helplessness. Cognitive theory is the result of impaired cognitive function. They think that this is a person that actually truly tries multiple attempts to control life situations, but or at least they perceive that they're trying, therefore they give up after. We also have reactive depression and preparatory depression, which is the grieving process. These are normal. Reactive depression in response to past losses, which could be a financial security or a job, or preparatory depression is more towards things and people. We have a subcategory of depression under bereavement. And this is characterized by the feelings of depression and related symptoms like loss of appetite, insomnia, weight loss. Though this is natural and normal, it's something you do need to watch. During this period, people have a tendency to feel extremely guilty. I should have done this, I should have said that, whatever it may be. Environmental stressors are associated with major depression. We also have dysthymic disorder. It's a persistent mood state, but more chronic than major depression. It's characterized by long-standing mild or moderate depression, but again, not as severe as major depression. In this category, basically, people are going to say to you, I've felt depressed all my life. They have very low self-confidence, hopelessness. There's no difference between the male and the female. You'll see 5 to 6% of the population be diagnosed with this disorder. You'll see signs of constant complaining, blaming themselves and others. Obsessive traits are noticed. And alcohol and drugs are very common with this. The diagnosis depends on the severity of the symptoms. Usually you want to see the symptoms for about 2 years in adults and 1 year in a child. Here we discuss major depressive disorders, and these occur in 20 to 25% of females and 7 to 12% of males. We're looking for a dramatic change in the past 2 weeks from what their previous lifestyle and functions normally were. We are looking for behaviors such as insomnia or hyperinsomnia, a weight loss or gain at a significant amount, psychomotor agitation, the feeling of worthlessness and excessive guilt, recurring thoughts about death. The physicians look to find 5 of 7 of these behaviors occurring to make the diagnosis. Postpartum depression is normal, takes place in 80% of women. This occurs after having the birth of a child. Just some mild depression feelings that usually goes away. 10 to 15% of the women actually experience postpartum depression, which take form of major depressive disorder, with the exception that they've had the birth of a child. This normally occurs a month or so after having the baby. There are several risk factors involved, including previous episodes of postpartum depression, no social support, a psychiatric history, and not breastfeeding. Many physicians overlook the diagnosis of postpartum depression. They're looking for a change of appetite, sleep, moods. Are they bonding with the baby? Are they having feelings of guilt? Are they taking care of the baby? Treatments include the cognitive behavior therapies, group or family therapies, and possibly some medication. Next, we have bipolar disorder. Bipolar disorder is characterized by mood shifts, hypomania, mania, and major depression. Its peak onset is late adolescence or early adulthood. There are 2 subtypes of being bipolar. There's bipolar 1, bipolar 2. Bipolar 1 is equal between males and females, and it's characterized by mania and a depressive episode. Mania is just an extreme energy, extreme agitation, just beyond what we see as normal. A bipolar 2 is most common in women, and it's characterized by hypomania and a depressive episode. And hypomania are just very euphoric, very energetic, can be very worrisome for those people that like to take go through risky behaviors. To manage bipolar disorder, first of all, the physician needs to recognize the signs and symptoms because of the social stigma and bipolar being used more as an adjective rather than a diagnosis. People are afraid to admit certain signs and symptoms, so that's something to look out for. These types of people usually have a self-medicating issue with street drugs. We can use therapeutic communication, let them know it's okay, and it's treatable. They need to follow a strict, sleep schedule, good nutrition, stay away from caffeine, and we also need to watch out for suicide. This is similar to the depressive disorders. Now we move on to anxiety. Before I discuss the panic disorder, we have to realize that anxiety actually is a normal, a regular anxiety can actually be normal. You'll usually get a headache, heavy sweating, tightness in the chest, some discomfort. These are normal symptoms, and they say it's actually good for you. It gives you a heightened sense of self that allows for a higher mental function and enhanced performance ability. So it's, as long as it's not all the time, a little anxiety attack here and there isn't too bad. A panic disorder is where you get this all the time. It usually stems in late adolescence and early adulthood. It's diagnosed by just the recurrent unexpected panic attacks. It's followed by persistent concern, the fear of having another, significant behavior change after the attack, worrying about the attack and its consequences if it's going to happen again. These panic attacks occur for 20 to 30 minutes, not more than an hour though. And again, you get the increased heart rate, sweating, shaky, dizziness. These are people that need to avoid things like caffeine, cold medicines, nicotine, alcohol. They have medications to treat this and stay on a consistent schedule to help reduce the attacks. Agoraphobia is when someone has begun to feel anxious or a panic attack in a certain situation, and they go to extremes to avoid that situation. They will plan their day around having to, whether it was at the Central Park, they won't go there again, and they will do everything they can to stay away from there. Social phobia is an irrational fear of humiliation, failure, and embarrassment within public attention. And again, these phobias can inflict on someone's life because they will go to extremes to avoid this kind of attention or these types of places. In discussing specific phobias, please, the movie starts on my end. Feel free to click on it and watch the movie. It's just 3 minutes of discussing what specific phobias are. I guess it kind of gave you a break from listening to me. But moving on, we have obsessive compulsive disorder, equally diagnosed in men and women. The thing with obsessive compulsive disorder is it's an obsession that someone has and a compulsion. The obsession part of it is regular, intrusive, and anxiety-producing thoughts that can have the fear of hurting others. Can be caused by a contamination. These people tend to question if they have done the behavior. For example, washing hands. The compulsion is a conscious, standardized, reoccurring behaviors. Repetitive hand washing, counting, checking. Tension stressors occur if the behavior is not completed. The anxiety begins. Unreasonable to the performer. If it's not done, if the hands are not washed as well as they wanted it to, it will produce anxiety. This is the most chronic of all anxiety disorders. The patient will devise plans to perform the behavior within routine. They will structure their schedule to make sure they get to perform this task. OCD patients are typically involved in substance abuse, and it's a lot of the times combined with major depression. The acute stress disorder is a disorder that occurs after the witness or being involved in an actual event or an observation. It's a fear that follows the event, lasting from 2 days to 4 weeks, actually causing impairment in one's life. This, if not treated, can lead to post-traumatic stress disorder. Symptoms of the acute stress disorder are dissociative type symptoms, re-experiencing, replaying the event in their mind, avoiding the place or avoiding the area, and the anxiety. Diagnosis is made by a timeline and symptoms and must be causing an impairment in the function of someone's life or their occupational area of life. Generalized anxiety disorder is the most seen disorder in primary care. It's basically excessive worrying, anxiety on daily events, affecting daily functions for 6 months or more. These are the people we consider as uptight, worriers. These people also have a lot of somatic symptoms, pains, aches, headaches, so forth and so on. Post-traumatic stress disorder. This is very similar to that acute stress disorder. Differences, again, the timeline. The symptoms usually start to occur after symptoms, like I said, normally within a year. It is stemmed by natural disasters, sexual assault, major accidents, violence, threats. Anything of that sort can result to the post-traumatic stress disorder. And the symptoms we're going to see is severe concentration difficulty, helplessness, fear, headaches, numb to emotions, irritability. Again, intense fear. The patient's impairment can actually be from mild to severe, and you usually see the fear continue longer than a month after the actual event. There's self-defeating behaviors, including substance abuse and sometimes suicide, to help alleviate the pain that these types of patients feel and recall. there are ways to manage this. Sometimes you don't know where it's coming from, so we need to find out what's causing the patient the anxiety. A lot of the times they're treated with the list of medications here, the SSRIs, the benzodiazepines, MAO inhibitors, beta blockers, and again, group therapy, one-on-one therapy, things of the sort. Next on the list of behavior disorders are the substance use and abuse type people. These include things like hypnotics, the use of cannabis, cocaine, amphetamines, alcohol, all leading to high-risk type behaviors. They actually categorize substance abuse into 3 different forms. Substance intoxication, which is the mild and the least affecting. These type of people tend to overdo it, but they haven't had any negative experiences from the use of the drug. Where you have the substance abuse, which it has negatively affect their life, and then you have the people that are severely dependent on it, where they cannot keep a job, they commit crimes in order to get the drug, so forth and so on. Diagnosis comes from a physician actually seeing the symptoms of a drug addict and speaking up. My next slide will have a CAGE survey on it, which is a quick little survey of seeing what category people that use drugs fall into. This is the CAGE questionnaire. When I Googled it, they actually, it was more specific for alcohol, but they have the one that is modified for including drugs. So the question in there, it's done on a point system. Have you felt you ought to cut down on your drinking or drug use? Have people annoyed you by criticizing your drinking or drug use? Have you ever felt bad or guilty about your drinking or drug use? Have you ever had a drink or use drugs first thing in the morning to steady your nerves or get rid of a hangover? If you answer yes to 2 or more of these questions, it's positive and they recommend further evaluation. Managing a substance abuse is a big problem because people that can't cope with their normal lives and normal issues, look towards substances to cope with them in that manner. Therefore, trying to get them to manage this disorder is very difficult. But a physician assessment of the patient, encouragement to the patient, and being supportive, offering them help. The patient obviously needs to want to help themselves. I looked up these numbers right here. These are all just local numbers. Point being that finding help is very easy. Plus you have the Narcotics Anonymous, Marijuana Anonymous, you have the Cocaine Anonymous, and Alcohol Anonymous. So there's lots of help for someone, but they do need to have encouragement and support. Now for a little change, we'll discuss some eating disorders. We all have heard of anorexia and bulimia. Anorexia is an eating disorder caused by an intense fear of weight gain. These people tend to be obsessed with the idea of not gaining any weight. You will see that they are excessively exercising, they're hyperactive. Severe cases, you'll find that they actually lose their menstrual period, low pulse rates, they lose their hair, but then they'll grow that body hair, very nervous around meal times. They're very self-critical. Where you have bulimia, these people tend to eat a whole lot, but then they self-induce vomiting. These people also use laxatives and diuretics to quote-unquote clear out their body. Again, you'll see some swollen glands. They have a fear to stop eating voluntarily. Their weight fluctuates excessively. Very secretive behavior. they will hide and steal to have these little binges of food, and then they vomit it. You'll see corrosion of the teeth, esophagus, sometimes internal bleeding, puffiness in the face. Binge eating is recurrent episodes of eating an excessive amount of food that's characterized by more than a normal person would eat in a short amount of time. There's more of an emotional factor to this also. The person feels like they eat and they know they're not hungry. They'll eat too much. They'll hide and eat. They feel very depressed after they eat, feel very guilty. With these types of people, you will see a history of weight fluctuations, depression, anxiety, a lot of self-loathing. This is more of a I know I'm overeating, but I can't stop type thing. So rather than words, here are a couple of charts. Obesity is also a disorder. It affects 30% of Americans. As you see on this chart here, the percentage of population older than 15 with a body mass index greater than 30. And USA is right on top of there at number 1. Obviously our diet leads to that, but there's other contributing factors that this little chart explains to us. Fast food, lack of exercise due to computers, tablets, cell phones. Fast food is also a higher fat intake, soda. People aren't eating like they're supposed to. People don't eat breakfast in the morning and then eat a whole lot at lunch. Poor parenting, daycare. People reward their children or themselves with food for whatever reason. Video games, vending machines. Convenience makes us fat. It's kind of, I think all of us can understand why that is. Attention deficit disorder is a neurological behavioral disorder. They look for inappropriate inattention, hyperactivity, and high impulse. To diagnose this, they look for a significant amount of impairment in social, academic, and occupational functioning. The above symptoms are at least for 6 months, and they occur within 2 or more settings, and this needs to be diagnosed prior to the age of 7 years old. There are 3 types: predominantly hyperactive, impulsive, predominantly inattentive, and then the combined. To manage ADHD, we have to recognize and treat on an individual basis. Every child is different and acts different and requires different attention. We also need to educate parents, people that live with the child, educators, the daycare, whoever the child comes in contact with. The use of behavioral therapy and medications are the preferred choice to treat these type of students, treat these type of kids. A pervasive disorder is a group of conditions that have delayed in developmental basic skills. Most of us know this through autism or Asperger's syndrome. Basically, somehow we're missing some milestones for the children. A lot of your primary care, like during the well checks, the doctor will notice that the child's maybe not up to the par of where they should be. The severity of the delay, the behaviors, and the best management of this starts with early diagnosis. Most of these won't be diagnosed prior to the age of 1, but need to be diagnosed by the age of 3. And the FDA actually is strong for risperidone to treat this, but antipsychotics and SSRIs are options as well. Here, this is from the National Comorbidity Survey, and it includes some disorders that we didn't discuss, but the majority of them are here, and it just discusses, just kind of shows the percentage of the population that will suffer from it in their lifetime, the average years until treatment. very interesting. This is our mental health survey from America. So just take a look at that. This is a nice little graph for child and adolescent depression. The purpose of this is to show you that when these are diagnosed as children, I know I didn't get too far into adult and children, and because all these disorders can actually be studied and learned about far beyond the capacity of this textbook, but this goes to show you that a lot of these disorders actually overlap. And like at the bottom, childhood depression, more likely to also have an OCD and Tourette syndrome, panic disorder, anxiety, ADHD, the behavior disorder, bipolar. It just goes to show you how they are actually overlap each other in some way or another. I just thought this was some interesting information. So that's the end of my presentation. I hope you guys are all awake. This chapter is extremely detailed in some aspects, and others didn't give you much detail. So I hope I explained it well, and everybody have a good day. Thanks.